Welcome everyone. It's my great pleasure to welcome all of you to our sixth webinar series on ethics and COVID. It's my great pleasure to welcome you all today. Today's topic is very exciting on vaccine ethics, but let me say that on behalf of the George Washington University's Milken Institute School of Public Health, and particularly our Office of Research and our Bioethics Interest Group, I want to welcome all of you again to this webinar series. I'm very excited that today we are going to be discussing ethics around vaccines in relation to COVID-19, and we have a panel of great speakers to help us do that. As some of you who are returning participants know, that this webinar series started nearly 2 months ago, and the idea is to enable a discussion forum for ethical issues that pertain specifically to a pandemic, in this instance COVID-19, but for those of us who are in health and medicine, and particularly in bioethics, we've been discussing and thinking about some of these issues that sometimes are becoming more acute, more important, and in some cases, unfortunately, more relevant in the context of COVID-19 as a pandemic affecting all parts of the world. I'm also particularly excited that over the previous weeks, we have participants from nearly all parts of the world. Welcome to colleagues in Latin America, in Africa, Asia, and of course, Australasia. And I know for some of you, it is either very, very early morning or it is actually late at night. So really appreciate you joining us. I also want to welcome all students who've joined us today. Please remember that you need to send us your PE documents or professional enhancement documents for signatures. My colleagues, Dr. Paul Ndebele and Michelle Yang will look after you. And on the chat board, you will find that information. Please, during this webinar, use the chat board to put up a question, a reflection, a comment, anything that you have, even while our panelists are talking and speaking. If you have an idea, you have a thought, you have a reflection, put it down. Not only myself, but my colleagues, Hina Sheikh, Paul Ndebele, Lawrence Canelli, and Michael Burden will be monitoring that. And I hope that we'll be able to get to as many issues and questions as possible. I do want to make an announcement. Unfortunately, a few weeks ago, we did have a case of some Zoom bombers entering our a webinar. If that happens again, we'll do exactly what we did that time. We'll cease our conversations, we'll chuck them out of the room and go back to business again. So if that happens, please be patient with us. Do not panic. Several of us have been trained to deal with them. Hopefully it'll work again if that happens, and we will address that situation. So with that, I'd like to begin. I'm very excited that today we are going to focus on vaccine ethics, and I have two great colleagues with me today. I'm going to request each one of them to give an opening remark for about 10 minutes. Our first panelist is going to be Professor Saad Umar. Dr. Umar actually doesn't need much of an introduction in the vaccine world, because he has a global reputation, has been working in the field for many, many years, but is the inaugural director right now of the Yale Institute for Global Health. He's a professor of medicine, professor of epidemiology, with joint appointments in both schools of public health and medicine. And more importantly, has been working on vaccines for a long time, and not just in this country, but around the world. He brings a great experience of research, but also a policy perspective, and has engaged in this dialogue for a long time. I am particularly delighted to welcome him because not only is he a friend, but we shared a medical school together. And if there are folks from Aga Khan University today in the webinar, a warm welcome to you. So over to you, Saad, for your opening reflections.
Yeah, so my original plan was to mime my way through the presentation. So now that you have pointed out that I was on mute, I will turn on my microphone. So first of all, thank you, Adnan and colleagues, for inviting me, and a special thanks for having this series, because it's important to remember that we don't dispose of our values, of our ethics in the middle of a pandemic. And an ethical discourse, ethical policy, ethical implementation requires discussion, debate, and so thanks for organizing the series. Before I get into vaccine-specific work, I just would formulate that the actions which are central to any policy But specifically, vaccine policy could be deontological. So that's one way of looking at actions that, they're appropriate, independent of their consequences. But when we talk about pandemics or large outbreaks, we have to be consequentialists. And we have to focus on what is the impact of our outcome. So in this kind of a situation, the burden is higher, not just in terms of having a sanctimonious, for lack of a better term, approach that things are black and white, irrespective of their outcome. We have to be realistic. We have to be consequentialists when we deal with pandemic policy, and that includes vaccine policy as well. So I'll briefly go through a few imperatives. At the core of all of this are justice issues. So no matter how you formulate it, from justice as fairness or other ways of looking at justice, the issues are that if you get a pandemic and if you are addressing it, how would you, these are distributive justice issues, meaning who gets the vaccine at what time. These are procedural justice issues. For example, how the policy is made. Is it science-based policy, or is it policy based on political whims of different rulers, etc.? Then hand in hand, so just equity can be a part of a justice framework, but equity needs to be teased out. So we can't be strict old school utilitarians unless we have an equity framework folded into that utilitarian framework. But we have to acknowledge that there are disparities in outcomes, in ability, in access. And so therefore, we, at the very least, at a minimum, a vaccine policy which is ethical has to be mindful of not exacerbating underlying inequities. In the sense that if there are communities that are already marginalized and often blamed for spreading the outbreak, they don't remain at the back of the line when it comes to vaccine distribution. But also, we have to be mindful of agency that people have, not just autonomy, but agency. So when we talk about communicating in uncertain, with evolving evidence, it is the responsibility to make sure that people have the information that respects their agency so that the decisions they have to make are evidence-based. And then we need to avoid seemingly beneficent paternalism. And so this icon represents what I think of, what I formulate as the knight in shining armor syndrome. And that often happens in policy that is made in Geneva or Washington or Addis Ababa for the rest of African continent or wherever. We need to respect the values of communities, societies, countries as global vaccine policy is developed when it comes to implementation of it. So I will switch to a specific aspect of vaccine policy that is likely to come up and that will be controversial, which is vaccine mandates. So why are we talking about vaccine mandates in a pandemic? Because, a few months ago, I think that was a prevailing view. A lot of people, in their sweet innocence thought that since we have a lot of disease, people recognize it's a bad disease. And if there's a vaccine to take care of it, a lot of people will take it. And now there is empirical evidence to suggest we can't take that for granted. But on the other hand, infectious diseases are just that. They are infectious. Someone else's behavior impacts my outcomes or my grandfather's outcome or my child's outcome. And so therefore, often societies use, even more open societies use mandates as a policy tool to say that if we are going to open up, if you're going to achieve herd immunity the right way through vaccination, that is, we need to have a high number of people vaccinated. So in that kind of a situation, mandates are on the table for these kinds of things. But if we are going to have that as a policy option, we need to be ethical about it, and we need to be hard-nosed about it. So with a few colleagues, I proposed a framework in 2019 around mandates that says that you don't talk about mandates unless you have ensured access to vaccines. So ensure stable supply, make clinics or facilities welcome, and monitor safety. So there's a higher burden if you mandate a vaccine on monitoring and ensuring vaccine safety. The other thing is mandates should not be the only intervention. It should be part of a package of interventions. For example, that should include diagnosis of reasons of under-vaccination, and the time is to start for that is now, not as a reactive modality. Use immunization registries and reminders, for example, performance feedback of the programs, and provide vaccination in communities, especially in hard-to-reach communities around the world. And then, if you create mandates, create ethical and smart mandates, that ensure that the procedures are fair, how they're developed are fairly sort of evolved procedures. They are based on scientific reasoning, not sort of whimsical policy making. Make penalties. If there are penalties, they should not be draconian. Mandates should not be a tool of societal vengeance on a small group of people or a minority of people, which is often the case in these kinds of situations. Then compensate for side effects. If there are side effects, compensate for them and have a low threshold for compensation. And then do not implement selective mandates, have consistency in policy. So applying this framework, a few colleagues and I, we have something coming out, came up with a framework for COVID-19 specifically, and to say that there should be 9 triggered criteria for state vaccination mandates for them to consider as a policy. The first of all is COVID-19, if COVID-19 is adequately contained in the state. So if the disease is rampant by that time, it's not controlled, that should be the first criteria. The second is the Advisory Committee on Immunization Practices, Committee on Immunization Practices that advises CDC and is responsible for vaccine recommendations in the US. In the global sense, it would be the SAGE, the Strategic Advisory Group of Experts, has recommended vaccination for the groups for which a mandate is being considered. The other thing is the supply of vaccine is sufficient. Evidence about the safety and efficacy of the vaccine has been transparently communicated. We do not know which specific product will be the first or which products will be in the first batch. And so sometimes, you have to weigh the risk benefit, but that should be effectively communicated respecting the agency of the population that you're implementing a mandate on. The other thing is that states should have had created infrastructure to provide access to vaccination without financial or logistical barriers, compensation to those who have side effects, and real-time surveillance of vaccine side effects. And then in a time-limited evaluation, voluntary uptake of the vaccine amongst high priority group has fallen short of the level required to prevent epidemic spread. That should be one of the criterion, and so don't use it unless these criteria are met. So I'll pause here and would love to hear the next presentation and then the discussion after that.
Well, thank you very much, Saad. This is really, really wonderful to see how you've started from reminding us about the approach of consequentialism being important for vaccines and going on to the 4 pillars of justice, equity, agency, and paternalism, and then winding your way down to a framework. I found your framework to be incredibly powerful in terms of access, the multiple interventions you talked about, as well as the mandates. And I loved when you said that it should not be a tool for societal vengeance. That is a quotation that I think is incredibly important for those in the policy world. So thank you, and we'll come back to your trigger criteria, and congratulations on having that coming out very soon. I am now really delighted to request our second speaker of the day, Dr. Alexandra Felon. She's a member of the Center for Global Health Science and Security here at Georgetown University. I'm excited to see that you are an adjunct professor of law as well at Georgetown Law, and obviously working in the arena of immunology, infectious diseases. Alexandra has not only actually worked in the US, but also worked with WHO and other organizations, and also in Australia, where you actually you have a legal career as well. So I'm really excited that you will also bring in a slightly legal angle to our ethical reflections today. Over to you, Alexandra, for your opening comments.
Wonderful. Thank you so much for having me. I'll just get the screen share going. So today, as highlighted, I'll be looking at talking about global vaccine justice and equity, and I really appreciate the previous presentation setting out these ideas of justice and equity, because that flows in quite neatly to what I'll be discussing here. So there are four different topics that I'll briefly go through in this opening remarks, and that's a quick look at what is the international legal regime for vaccine distribution, and vaccine distribution will be my sort of focus here. How do we actually guarantee an ethical framework, or do we guarantee an ethical framework through international law for the global distribution of vaccines? Looking at some of the emerging legal issues that we're seeing, the ethics of advance purchase agreements and how that will impact global vaccine justice and equity through distribution. Perhaps the next step of what we require from the global community being an analysis of this prioritization of how we actually do distribute vaccines globally, and then perhaps some future potential ongoing equity challenges that will raise additional ethical considerations in vaccination certificates. So looking at international infectious disease laws and COVID-19 vaccine, we actually don't have a huge amount there. The primary piece of international law for infectious diseases is the International Health Regulations, or the IHR, which some people may be familiar with. It's the law under which a public health emergency of international concern was declared on the 30th of January by the WHO Director General. And when that declaration is made, there is scope for vaccines to be included in the recommendations that the WHO gives to countries. But obviously, this is an emerging infectious disease, and we don't yet have an approved vaccine available. And so the recommendations don't yet include anything about the vaccine and how countries should respond or use vaccine or distribute vaccine. But it's possible that in the future, that will become an operative provision, and we'll see that being used by the WHO. But that's very high level. It really doesn't help us deal with some of the ethical challenges or address justice and equity concerns about global vaccine distribution. There is an obligation on countries around the world to provide international collaboration and assistance to each other. It doesn't expressly talk about vaccines or about vaccines in the response, but there is this duty that member states did agree to back in 2005, in which we could perhaps see the basis of some sort of cooperation for vaccine distribution. But apart from that, there aren't any vaccine distribution guidelines in essentially our main piece of international law to deal with pandemics. And so there are other areas of international law that have come in and filled the gap that are relevant for COVID-19 vaccines. The Nagoya Protocol is a piece of international law that is not developed by the World Health Organization, but is within the ambit of the Convention on Biological Diversity. And it's relevant because it's a piece of international law that expressly sought to address past colonial and historic injustices, where largely wealthy countries would go to poorer countries, or countries that would go to countries with colonial histories potentially and extract resources without any equitable sharing of the benefits from the use of those resources. And the Nagoya Protocol tries to redress that by allowing countries to set the terms in which other entities or institutions can actually access resources from their country. And in exchange, they can require the equitable sharing of benefits. And that might include, for example, in exchange for access to a pathogen sample, the recipient agrees to share any vaccine developed from the use of that sample. These are very specific scenarios, but it's not impossible that there are existing material transfer agreements or contracts that exist that have been developed when the original SARS-CoV-2 virus samples were being shared and hadn't yet become a pandemic globally. So that's just something to keep in mind. And there is a further relevance, and that is that because pathogens are so specific, there have been calls for an international treaty that specifically governs the sharing of pathogens within this realm. And so this is potentially an area of future development, whether through the IHR reform process that is very likely to occur following the COVID-19 pandemic, or any sort of specific agreement. And within that, that might include arrangements for how vaccines developed from pathogens are to be shared and distributed. We have a paper recently in Science that sort of talks about some of these opportunities. But again, this is a fairly limited, bilateral, ad hoc, not comprehensive, multilateral sort of global equitable distribution framework. There is precedent for non-COVID vaccine distribution. The Pandemic Influenza Preparedness Framework, which is consistent with the Nagoya Protocol, specifically applies to pandemic influenza vaccines. So when you access pandemic influenza samples and then you develop pandemic influenza vaccines from those samples, this framework provides a distribution model, if there is a pandemic, of how those vaccines are to be distributed globally. Again, it only applies to pandemic influenza, so not COVID, but it has been touted as a potential model for non-influenza pathogens. Now, the way it seeks to distribute vaccines is to prioritization of to developing countries, particularly affected countries, according to public health risk needs, and particularly where those countries do not have their own capacity to produce or access influenza vaccines. So you can see the role of the WHO here is to distribute that pandemic influenza vaccine to countries that don't have that capacity or have a particular public health need. And that can be informative for perhaps the frameworks that we might see developed for potentially a COVID vaccine infectious disease law. So in the recent weeks, we've seen different ways that countries have approached the idea of a COVID-19 vaccine. President Xi of China has come out and said that if China were to develop a vaccine, or any vaccine that China develops, would be a global public good. And the idea of a global public good being that there would be some form of global distribution, that it wouldn't be about keeping it as a private good that is to be sold and traded. The idea is that it would be distributed around the world. And this sort of framing is quite interesting, because we can then contrast it with some of the practices that we're actually seeing occurring. And that is, this was one from last week, that the European Union had announced that it had secured access to potential future coronavirus vaccines through advanced purchase deals with pharmaceutical groups. These sort of advanced purchase deals are not unusual. They happen all the time. There are a number that are already in place from countries for future pandemic influenza, even though we don't know what that future pandemic influenza might be. And so it's unsurprising that this has occurred, and a number of scholars and a group of scholars that I work with and have wrote that science paper with have been looking at this in a little bit closer detail. So I want to have a look at what are some of the ethics of these advanced purchase agreements. So advanced purchase agreements are essentially where typically a country, but it could be an international organization, agree to purchase a certain number of doses of vaccine in advance. And sometimes the vaccine may not even exist yet. It's sort of a future promise to purchase. And the real questions to ask, and what makes, to really differentiate the basis of this, is who is the purchaser? Who is purchasing the vaccines? Is it a country? Is it an international organization? And who are they purchasing for? And so if we split this up into the two common ways we see advanced purchase agreements for vaccines operate is, say we have international organizations, whether it be WHO, UNICEF, Gavi, another international organization that purchases these vaccines for global distribution. And the aim of this is typically to address market failure. The idea is that they purchase it and they can then distribute it typically to countries that do not have local manufacturing capacity or are particularly affected or don't have the economic purchasing power to be able to purchase vaccines. In contrast, if we look at that example I just shared before, if we look at countries, so the European Union as a regional bloc, we look at, say, France specifically, or the USA, the advanced purchase agreements that these entities are entering into for regional or national distribution. It's prioritizing, guaranteeing supply and securing national supply for their own citizens. And if you think about the potential broader impact that might have, that you can't really separate that out from the global equitable distribution of vaccine, because it means that there's a guarantee of supply. This becomes even more complex if you add on the layer that these countries are maybe the countries that have that manufacturing supply domestically. And so there are other national laws that might come into play that prevent global distribution of vaccines, such as export control laws that prevent that vaccine being sent overseas, even if another country has an advanced purchase agreement. And that's relevant because we've seen that in past pandemics. We saw that in H1N1. And so these are things that need to be proactively thought of, proactively considered. And really there is this now priority that we have to have guidance developed for global distribution prioritization for vaccines. There was at the World Health Assembly in May, the first virtual WHA resolution adopted for COVID-19 response that did talk about vaccine distribution. It was silent on intellectual property rights. Actually, well, it was deferential to intellectual property rights, but didn't really give us a huge amount of guidance about where to go for global vaccine distribution. And that makes sense given the short time frame. So some of the questions that need to be asked if we develop such prioritization is, these are questions that are occurring at the global and the national level. So the first thing is do we prioritize healthcare workers? So this is taking from past pandemic prioritization assessments for vaccines. You know, healthcare workers, because without our healthcare workers, we don't have a response. Our communities are less safe, but also they're particularly vulnerable and at risk of contracting COVID-19. Other essential workers, similarly, because if they're taken out of operation, the impact that has on society. You know, defining who are essential workers is really key. In some simulations that we run for pandemics, politicians want to include politicians in essential workers. And, you know, there's some argument that, you know, continuing the functioning of government is critical, but that would include also things like grocery workers, sanitation workers. And then of course, vulnerable populations. And then we have a question of defining who are the vulnerable populations, whether with COVID-19, we're talking about our elderly populations, we're seeing significant racial disparities. And so is there an argument that there should be prioritization to particular subgroups in our populations? There will be arguments likely that younger people potentially should be vaccinated because because of the economic impact of COVID-19. Now that's, you know, I don't necessarily agree that that's how we should be defining it, but there is an ethical duty to go through this process so we have clarity and to be aware of the likely arguments that are going to be raised. And then on the global level, you know, if we think back to that pandemic influenza preparedness distribution priority, do we prioritize countries who are least able to purchase or produce vaccine? What about countries that are least able to actually implement lockdowns effectively? You know, it's in New York, we've just, you know, been in lockdown for months, been able to manage a certain degree of lockdown for many in society, but not all. What about in countries where those lockdowns are actually unable to be implemented effectively or equitably because of existing global disparities? Is there an argument ethically that those countries should have access to the vaccine because they don't have access in practice to non-pharmaceutical interventions? In the longer term, this is the final thing I'll just talk about, is there are going to be ongoing ethical considerations about how we emerge from this as a global society and the potential risk of entrenching inequities. And one of these things that could come up, policy measures could come up, are vaccination certificates. Currently, under the international health regulations, there are provisions for yellow fever for countries to require travellers to have yellow fever vaccination certificates when they travel. There is a possibility that WHO member states might consider including COVID-19 vaccination once we have a vaccine for international travellers. And there'll be a range of questions around that, like, will it cover all the different types of vaccines that are available or only some vaccines? How do you will we incorporate this into the IHR? How do you evidence it? Do we use the same model as we have for yellow fever? And if we don't have global distribution of vaccines, if you require these certificates to travel, then there's going to be further entrenching of existing inequities globally that have significant socio-political economic impacts. Something just to note, vaccination certificates should also be distinguished from immunity passports. I've written a piece recently in The Lancet about this, and I'm happy to discuss this in the questions, Q&A if relevant, but there is a significant difference in the incentives and the legitimacy of, say, immunity passports that try and say that you have immunity to COVID-19 versus vaccination certificates. So I will leave it there. Thank you very much, and I look forward to the Q&A.
Thank you very much, Alexandra. I really appreciate your bringing in, first of all, a global ethical and legal perspective. And thank you for reminding us actually of both international health regulations, the Nagoya document, and our previous experiences with pandemic preparedness and distributions with respect to influenza. I thought that was very important. And your closure at the end with respect to vaccine certificates and immunity papers, etc., that we might get into. So I'm really happy that both of you have covered a lot of ground. This is obviously a very vast issue. We are already getting questions on the chat board. Now is the time, ladies and gentlemen, for those of you who are participating in this webinar to put your reflections, your comments, your concerns, anything that you would like on the chat board. So I'm going to really start off, Saad, maybe with you, because the question is, when we do have a vaccine, and we'll come to a little bit of the preliminary question about how to get there, but who gets it first? It's a question that a lot of people are very worried about, and there are two levels, individuals and then countries. So let's start with individuals and get your responses. And Alexandra, you might think about this as well. I might come to you as well. So over to you, Saad.
So I have the good fortune of being part of the SAGE working group that is drafting 4 SAGE recommendations, some of the prioritization. And so one of the, and without speaking for the group, and I want to clarify that, so at least my thinking and a few other people's thinking is that we should, because the default muscle memory we have as public health professionals is to go towards a utilitarian framework, old school utilitarian framework. But the idea is to clarify our values first, before we clarify, which groups should be prioritized. And so starting with the values, there could be multiple ways, and it's not, this is an evolving process, and this is, again, my personal views. The values should be based on multiple factors of human existence that contribute to our well-being. It could be social, it could be economic, it could be health. It is health at the center of it. But it should be privileged. Health should be privileged in that kind of value clarification process for a couple of reasons. There are other tools for mitigating other impacts, etc. And vaccines should fit as a policy tool within a larger framework. The other thing is societies. There's a broader consensus that the expectations from vaccines is primarily for health outcomes. It is okay to then have second order effects and full value of vaccines, but that conversation societies haven't had. So my personal opinion is, in that value clarification process, take a broader view, but privilege health as a consideration. The second thing is to focus on equity at the outset. That should be at the core of it, because it's a simple notion that is, again, shared with between most civilizations, that all lives ought to be treated equally. I wish I could say they are created equal. That would be a naive interpretation of it, but they should be equal. That's a common societal aspiration. So again, equity is another value in terms of prioritization, etc. Discussion. And I'll come to, maybe in a future question in terms of keeping those on mind, where I see personally which specific group could be prioritized, in a second. But these value clarification processes then logically lead to a few specific groups.
No, thanks, Saad. I think that your insistence on values was clear in your opening message, and I think it's very important. So, Alexandra, from where you are, from your vantage point, you already enunciated how WHO has suggested some priority criteria. But what are your thoughts, both at the individual and or the country level?
Yeah, so I think the first thing is to acknowledge that there is actually an ethical duty on governments to be doing this now, right? So it's not just an ethical duty about how vaccines are distributed, but this process is an ethical duty on governments. And I very much agree with Professor Omar's comment about health being the first order priority. That really must be central. And so one of the ways that I look at whether we're talking at the national decision-making level or the global decision-making level is elements of good governance. How do we ensure that this process has that procedural justice, right? And that's kind of our framework to then work out, because different communities different countries will come to different conclusions about what their values are and how they want to do this prioritization. So how do we create a process that helps do that for different communities? So, you know, I sort of look at the five elements of good governance. The first is that any decision-making body, whether it be WHO, whether it be a SAGE, there is accountability. So the first step is there's accountability, and that doesn't need to be about blame. That's just more about there is a responsibility to make decisions, right? Transparency, that the decision-making process is transparent. And generally we find, like, if you look at the studies that are being done, regardless of what the outcome is, generally how that allocation or distribution decision is concluded, if there's transparency of how that decision was reached, that really helps people understand and potentially accept the process. Participation, so there has to be appropriate representation from different members of society who will be these decisions are being made for. You know, that includes across gender, across race, across religion, culture. Equity, so that goes to the point that Professor Amar was making. And then the rule of law is the one I add in there, not just because I'm a lawyer, but because what happens is you make these rules and then you have to follow them. So there has to be consistency in how these are followed. You know, and the final thing I'd sort of say on this is, you know, to poorly paraphrase Paul Farmer, is, you know, there is a real risk in this process that we will have an outcome where we essentially judge as a society globally and nationally that some lives matter less than others. And that is what we should be avoiding. And that is why we need to be focusing on this process now.
No, I think, thank you very much. And thanks for those 5 criteria. I think that's a wonderful sort of list that we can all take to a number of decisions. So Saad, one of the things that people are concerned about is the rush to produce a vaccine. And as you know very well of all experts, this gives credence to the fact, oh, will it be ready? Or are we shortchanging the process? Should we use the traditional RCTs or human challenge studies? What are the ethics around the process and the rapidity with which vaccines should be developed? What are your thoughts around that?
So the two aspects of it. So one is more sort of a policy vaccine acceptance aspect. And the other is, you know, and then that includes biological aspect. The other is procedural justice aspect. Right. So if you're going to ask a bunch of people to take a vaccine, and from a very ethical perspective, we owe it to the population to make sure that we don't cut corners in vaccine development. Having said that, what I have seen in terms of mainstream vaccine development programs in most countries and most entities, it is moving faster than anything we have done before. But right now, the steps that have been taken right now so far have been, the speed has been a function of finding efficiencies in the process. But we should ensure that continues to be the case. That it should be that you're doing, for example, animal studies in parallel with some of these, you know, some kinds of animal studies are being done in parallel, because for certain vaccines, the safety profile of the platform is such that you can go in human studies, etc., that you have adequate sample sizes. You're doing safety monitoring, and one of the things that I'm engaged with WHO is actually specifically making sure that countries are ready for a rigorous assessment of safety. And we should be ready. You know, if there's a safety signal, we should go after that with the same vigor and the same rigor as we go after efficacy and effectiveness hypotheses. So those are the things, and part of it is perception as well. So, you know, Operation Warp Speed, you know, as a sci-fi nerd, you know, maybe you could have called it Operation Long Live and Prosper or something. But
yeah.
So the bottom line is that
no, I think that's a great message.
Yeah.
That's a great message that you are looking at, and I like the way you're phrasing it. You're looking at the efficiency of the system as opposed to creating completely new pathways or ignoring side effects, as many of our participants have talked about. So, Alexandra, just on this point, some of our participants are appropriately, I think, reflecting that just because a global body is involved, let's say the World Health Organization, which has, of course, come under fire, at least in this country, just because a global organization does not mean that the principle of equity, with both of you actually have talked about, will actually be implemented. And that the notions of distributive justice that both of you have alluded to will be ensured. What are your perspectives on that? I mean, what is the role of that global body, and how can we assure that the justice concerns are heard?
Yeah, it's an excellent point. I think the starting place for me is to remember that the WHO is a secretariat. So it's not an organization that comes up with its own values and decisions. And obviously every system will reflect the values and the people who created it, you know, back in 1948, right? But it's a secretariat, which means it operates to implement or act as member states direct it to do so. And so all of the decisions, whether it be sort of expert appointed bodies that tend to have geographical representation or seek to have geographical representation, but not always efficiently have sufficient representation, they are a creation of the member states and what member states drive. And there are 194 WHO member states. They all have one vote and one voice. And that is one way of trying to get that participation, that equity and that representation. It doesn't always work out. A lot of the decisions that will be made will typically be done at the World Health Assembly, which means you get that member state direction. I think the broader geopolitical interactions with the WHO that we're seeing are really going to play out in this vaccine distribution in many ways. If the US continues on its path to withdraw from the WHO, that is a very powerful pharmaceutical player that will not be at the table in many of these distribution discussions. There are many in the global south that have said that, well, that's actually potentially a really good thing for getting vaccine distribution for this particular issue. Obviously, there are broader global health impacts of that decision. And so the political players who are going to be involved will have a significant impact, but it's important to remember and that the WHO is essentially the creation of member states and what countries put it. So
no, yeah. Thanks for reminding us, Alexander. That's very important, because sometimes we think that the WHO is its own body, but it's really the health ministers of the world who represent that. So Saad, you have worked extensively in low and middle income countries, and we have participants from different parts of the world. And some of our colleagues are concerned about, for example, poor capacity, poor vaccine logistics, rural areas, weak law enforcement, so many challenges to the idea of vaccine implementation. What are your thoughts about now COVID-19 on adding on top of all of the other vaccines that we have to do? What can countries do?
This keeps me up at night. Sometimes even literally, mostly sort of metaphorically, because look, we as a global community, and even in the US domestically, we used to be the benchmark of the world's public health interventions. I think we'll have to revisit that honor after the pandemic is over. But certainly globally, we have never vaccinated the adult population in the numbers and in the proportions we would need to vaccinate to really get this outbreak under control. And the depressing thing is that realization hasn't sunk in immunization programs. WHO has been rightly busy with fighting the outbreak. The immunization folks are keenly aware of this, but you can't expect sort of a small-sized body in Geneva to lead immunization programs throughout the world. So countries are like big countries like India, like Brazil, like Pakistan, even in Europe. We are not setting up systems. So we are waiting for, one fine morning there will be a news item in the Guardian or the New York Times or whatever, that there's a vaccine available and magically everyone will be vaccinated. No, that's not going to happen. So that's a big gap. So what they can do now is to actually set up the system to distribute, to deliver, to vaccinate, and to monitor the adult population, which was likely to, whichever the subgroup may be, they are broadly within the adult population in the first go. Then we may come down to the rest of us.
No, thanks. And I think you're right. It does. This is one of the eternal questions, so to speak, in public health, right? How to implement these vaccine programs. And in some ways, Saad, while I have you online, just a quick reflection in terms of the fairness of distribution. So, Alexander talked about how WHO says essential workers, but hypothetically, you have essential workers in low and middle income countries, but also and essential workers in high income countries as well. And in a global pandemic situation, there might be trade-offs. And there's great concern, obviously, that either non-health factors, power, privilege, money may determine that distribution. Have you been kept up at night with those thinking as well?
A little bit. And so here's the thing. There are two levels of distributive justice between nations and within nations, and they need to be treated not independently but in parallel, and both deserve our focus. And so there should be transparency in, again, values, etc. And so I think it would be naive to think that we would have a one big pool of people where there are sort of health workers and then we universally at the micro level decide. That hasn't happened, and that has practical aspects, that has political aspects in a good sense, not in a bad sense of the world, because governments, when politics is at its best, works through holding rulers accountable, etc. So in those kinds of, in those kinds of situations, we will have to have two-tiered distribution. So the current thinking is that the country level distribution will be based on the second, or at least recommendations for distribution, generally speaking, what I've been hearing, would be based on overall risk groups within each country. And then the country gets to decide whether they follow that logic or they devise the logic. I think within the groups, I think I would be surprised if the elderly, healthcare workers, I would advocate for healthcare workers stratifying them. So those who are engaged with high risk procedures like intubation, etc., have an exponentially higher risk than others, etc. So healthcare workers, then people with comorbidities, and then I would say do a further stratification. For example, hypertension is way above all sorts of other comorbidities, and then come to essential workers, etc. But then all of that depends on what your primary policy goal is, which is it preservation of life or preservation of life nuanced by preservation of other well-being factors, etc.
No, thank you. And these are complex questions. These are very complex questions. So Alexandra, one thing I want to pick up from what Saad said, and some of our participants are asking about this, and push you a little bit from ethics and legal into political realm. And because, there are leaders, and we have one of them, that sometimes does not accept the full spectrum, the full factual details of how COVID-19 is affecting. And that has implications. It had huge implications in the UK, as you saw across the pond. It has implications for many countries. Brazil is another one where we are noticing differences between. So what are the ethics of dealing with this when facts are sometimes refused and rejected, and evidence is denied? It frustrates certainly researchers like us, but maybe from a legal ethical viewpoint, you have some perspectives on that.
So I think it's a multidisciplinary frustration. I think that one of the biggest challenges will likely be misinformation with the vaccine distribution. I think that's quite clear now. We're already dealing with it pre-vaccine, just simply with the basic realities of how serious this disease is, how much it's spread. And that is an ongoing battle. And I think for a lot of scientists, a lot of researchers, public health researchers working in this, the realization that this is as much a political challenge and a governance challenge as it is a scientific one has been a bit of a shock. I think for many researchers, there's this feeling that, if we have the evidence base and if we communicate that evidence, then we work through and we deal with these, our distribution questions very technically, and we come to a solution. The reality is these governance challenges are perhaps the most significant challenge that this pandemic has demonstrated, both nationally and globally. you know, I think it is something to be really concerned about, particularly as we're seeing states, say in the United States here, being reopened, just contrary to all evidence. And I have really serious concerns about how we're going to deal with that trust. Now, there are experts like Professor Omer, you know, Professor Julie Lisk in Australia, who are really experts in how you build that trust and how you deal with those challenges. And I think that will be crucial, but there will be a real risk that we also get distracted by it. And that becomes a self-fulfilling prophecy and a narrative that we're spending more time dealing with rather than, you know, I think there'll be a point at which getting that vaccine out will be a priority and engaging. So it's a delicate balance. And I think an underestimated in all of our pandemic preparedness assessments, you know, a great example. So in the Global Health Security Index, an index to measure pandemic preparedness around the world, the United States ranked #1. For its capacity. And that was unsurprising to many people because of its technical capacities. But if you drill down and look a bit more at the actual assessments, when it came to public trust in institutions, it got 0. Yeah. When it came to the socioeconomic environment for ensuring good governance, it was 59th in the world. So I think we've underestimated the impact that political and governance issues have on our pandemic preparedness. And I think that's going to significantly shape how we go forward, rather than looking at, do we have lab capacity? It'll be, do we have public trust?
I think both those points, I think the trust as well as the role of misinformation, particularly right now on social media, even before COVID-19, one was dealing with this plethora of misinformation going on, but now it has become a huge, huge issue. So one point that I think is on the chat board that I haven't talked about, and I want to make sure I capture it in the last couple of minutes, is this notion of who makes money off vaccines, right? Who has a patent for vaccines? And are there vaccines that will allow pharmaceutical companies to get richer? There's a lot of concern around this notion. Could you clarify for us what is the current sort of thinking around it and recommendations around that?
So look, there's a subtle balance. Unless we decide as a world community that we are going to have nationalized production of vaccines and build a system in 3 months for that, which we don't. Countries don't produce vaccines, and it's a longer discussion whether that is in the better interest of the overall population of the world. Most of it, even in low-income countries, these are private enterprises that are doing that. So that's number one. I don't think that's going to happen. We're not going to nationalize the vaccine development and manufacturing system. On the other hand, we cannot have unfettered price gouging. We cannot have access issues develop because of short-term greed. So there are a few ways of doing that. So there's a sort of a big regulatory hammer, and then another hammer of public opinion, which is still a big hammer, but made of jello, in a sense that pushes, nudges, and shames entities into doing the right thing. And so there will be a role for regulation based on jurisdiction, et cetera, of making sure that while ensuring a robust marketplace, because we don't have a nationalized vaccine development and supply system. You don't want to develop vaccine shortages in the middle of a pandemic. There are checks, and there are sort of countries have models while they have preserved market and market access, a good marketplace while having regulation. But also, I think in this kind of a situation, the voice of quote unquote influencers and those who speak or contribute to the public discourse would be important to keep things in check.
No, thank you for that reflection. And that's really important for people to hear, because I think sometimes people get confused between, as if there are other options available, and you're pointing out that those systems don't exist. Since I have you, Saad, would you like to take a minute to make a final closing reflection? We are going to start winding down. Any final thoughts as you close out your contribution?
Well, so at the end of the day, it's not the biology that is dictating the epidemiology in various countries. It's policy. And one thing that we have learned in this outbreak is that leadership matters. It matters in overall disease control, and it matters in vaccine policy as well. So we should all remember that, maybe in this fall, or you know, going forward in terms of as things roll out, that we should demand both from our technical leaders, but also from our political leaders, effective policy.
Well, thank you very much for that reminder. And that is my favorite hashtag, Leadership Matters. So I couldn't agree with you more. Alexandra, over to you for a final thought, a closing reflection on any of the points or the discussion raised.
Yeah, I completely agree with Professor Maurer on this point about politics and governance. And I think, if anything, it is an opportunity for us to reflect on how do we build trust, how do we build accountability, how do we build participation and make our systems more equitable and more fair, to preempt these issues, but also be able to respond more effectively during a pandemic. The one thing I would close on is that, you know, this is a marathon and we are still actually in the early stages, and there is no guarantee of silver bullets. There's no guarantee of clarity on the potential, you know, one single clear answer. We should be preparing for a range of possibilities in a way that is participatory and transparent and equitable.
No, thank you very much for that reminder, because indeed it is not only a marathon, but we're also preparing for the next pandemic, and there will be one at some point in time. We must prepare as good public health professionals. Ladies and gentlemen, this conversation obviously could not cover every single aspect of vaccine ethics and COVID-19. But I think that, I hope you agree, that it has been a remarkable foray into a spectrum of discussions, from looking at vaccine production to distribution, to issues of justice, issues of prioritization, issues of safety and harm reduction, as well as that of beneficence and benefit sharing. I think that this is just really the beginning of a conversation. I'm very, very excited that many of you are partners in that process. I'm truly grateful to both Professor Saad Omar and Dr. Alexandra Felon for joining us today, sparing their time. I know how busy they are. So really appreciate their inputs from an ethics, legal, and technical viewpoint. I hope that you have enjoyed this webinar. Please note that exactly 2 weeks from now, on Tuesday, July the 7th, our next webinar will be focused on racial disparities. So it'll be focusing on ethics and COVID, with a focus on racial disparities, with I hope half the discussion of the US and half from a global perspective. I truly also want to thank the whole team here at George Washington for setting this up. Thank you all for joining. I'm grateful for your participation, and I apologize to those of you I could not get to. There were other questions about what if we don't find a vaccine, which is a wonderful discussion, a counterfactual that we must think about as well. Thank you, Sa. Thank you, Alexandra, again. Have a safe and wonderful day, the rest of you, and hope to see many of you back next Tuesday. Bye-bye.